Morning, madam.
Good morning, Dr. Mahalakshmi.
Dean has not become free, or
A lot of problems, sir. Today MCA inspection is also there. He said that as soon as you ask me to join, I will join.
Yeah.
So I'm actually calling.
yes,
Good
join.
morning, everybody.
Good morning.
Morning,
And
sir.
done with that, and the NMC inspection just now started. Dr. Bhatt, good morning to you.
Morning.
Hello.
Good morning.
Oh,
Our
Dr.
speaker
Nagaraj,
also
nice to see
joined,
you.
sir.
Mahalakshmi, good morning.
Morning, sir.
Dr. Geeta.
Hello, ma'am.
Dr. P.F. Kotur is Dean ABMC. He's basically anesthesiologist. And another designation is he is my husband.
Okay.
Then Dr. Mahalakshmi is Dean of Academics, and she is very enthusiastic, and all our academic programs happen throughout the year, and she is the main instrumental person in that.
Oh, nice to meet you, ma'am. Nice to
Nice
meet
to
you. I
meet
think it's very
He's the
important.
ring master.
She keeps everyone on toes, you know.
Very nice. Very nice.
Okay.
Ma'am, the other speaker also has joined, madam, or they will join little later. Dr. Savita.
Savita has not yet joined. I sent her message to join, but I don't know what. I did not get any reply till now. Morning, if she has sent, I just check.
He may join after some time.
Yeah. Maybe
Yes.
because very busy lady.
Can we start, ma'am? Because I have another meeting at 11:30.
Yes, we can start. Savita will join most probably after 10:45, like that. She told like that. Ravi, we will start.
Yes, madam.
Students will slowly join.
Lata. No, the Durga will give you. He will call you. Once he will
Sanjit, unmute yourself.
send you a link. Then he might join. You keep also your link.
Yeah,
Also
you can start up.
Okay, sir.
Then when he appears, he will come. Or you can give a courtesy call also. Sir, we are waiting. Exam is going on. He had visited ABMC. He is a nice man from Jaipur. He knows about it. Okay. इसका नंबर ले लो तुम दुर्गा के पास है देखो.
So if you can enable me for sharing, I will be able to start. Or if somebody wants to introduce, I'm happy to get introduced before.
Start.
So good morning, all of you. Our AVMC IIC is fortunate enough to get this opportunity to organize this Impact Lecture Series sponsored by the Ministry of Education with the theme of Innovation in Diagnosis and Treatment of Breast Cancer. With warm greetings and a very good morning, I, Sanchit Kushwaha, a first-year MBBS student and master of today's program, welcome you all to our today's Impact Lecture Series. I think we all agree that there cannot be a better way to start this wonderful morning than a remembering of the Almighty. So let's all join Ms. Meenakshi Menon, a first-year MBBS student, as she sings a melodious and soul-warming prayer.
या कुन्तेन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माशुतशङ्कर प्रभृतिभिः देवै सदा पूजिता सा मां पाद सरस्वती भगवती निःशेषजाढ्याप्रहा।
Thank you, Meenakshi, for such a soulful prayer. Now I'd like to invite Manomai Gonella, one of our finest first-year MBBS students, to extend AVMC's warm hospitality by welcoming our guests.
Manonmai.
A very good morning to one and all present here for this impact lecture. I, Manomai Gonella, of first year MBBS, take the pride in welcoming our guests today. I would like to extend a hearty welcome to our guest speakers, Dr. Geeta Manjunath and Dr. Savita, who have done phenomenal work in the research and treatment of breast cancer and are going to share their experience with us. Thank you so much for being here. I would like to invite the external members of ISC who have been constantly supporting us. I would like to welcome our Dean, Professor Dr. P.F. Kotur, who is always in the front line to support our Innovation Council along with all of its activities. Our enthusiastic Dean of Health Professional Education, Dr. Mahalakshmi Ma'am, our Director of Medical Research, Dr. Vishnubhat Sir, our Vice Principal, Dr. Rajan Sir, Vice Principal of Student Affairs, Dr. Arunachalam Sir. Welcome. Our conveyor and backbone of IIC, Dr. Pushpa Kotur Ma'am, who have all blessed us with their presence. I would also like to welcome our HODs, professors, and our wonderful participants.
Thank you, Manomai. Moving on, you would be interested to know that today's program has been organized by AVMC's IIC organization, which is the only innovation council of a medical college selected by the Ministry of Education for the conduction of this kind of event. Our innovation council is quite vibrant. It was inaugurated on 22nd June 21, and in the span of 6 months, our council has bagged 3 stars out of 5 ranking and 2 stars out of 2 from December 2021 to June 2022. This has only been possible due to the vision and direction of our Dean, Dr. P.F. Kotur Sir. Sir has been and continues to be the spirit of our college's collective progress and achievements. Sir, I humbly request you to start our today's program with your welcoming and insightful words.
A very good morning to one and all over here. Today the resource person, Dr. Geeta, the CEO of the Nirmal Health Analyst Bangalore, and my colleagues, Professor Bhatt, Professor Mahalakshmi, Professor Pushpa, then all other Ravi Kumar, and my dear students. Yeah, one more feather in the cap of AVMC. We identified ourselves as one of the few institutions in the country, one of the few medical colleges in the country who have the unique distinction of having established the innovative cell. And now today we are one more milestone rather. we have been awarded to conduct impact lecture series by the Ministry of Education, Government of India. And today is the first lecture. I, on behalf of AVMC, University at large, and our management, Honorable Chancellor, Madam Chancellor, and the Board of Management, am privileged to welcome Dr. Geeta, and of course, Dr. Savita will be joining after a while for this impact lecture series. And I'm sure, with their specific focused experience in the field, they, with the impact lecture series, will be of immense benefit to all our staff and students. Myself being an anesthesiologist and being a member of the senior member of the medical fraternity, a couple of thoughts certainly. We all know that the breast cancer is one of the leading cancers that occurs in women, and it affecting the mental health and the physical health as well. And it is now proven beyond doubt that early screening, either molecular screening or imaging screening, will has a definitely got a prognosis. There are incidences, the lifespan, almost having a normal lifespan after early detection and treatment. Those kind of modalities are available. And now there has been a explosion of a kind of explosion and the incorporation of the artificial intelligence, which will result in deep learning in every field, including our medical field. And artificial intelligence has contributed in the past almost decade significantly for a variety of biomedical problems getting solved. And the mammography is the one of the can say gold standard for early screening, and if it is incorporated with the artificial intelligence, has been found to have a very good results, outcomes. So these are some thoughts are coming to my mind. We have the people who are experts in the field. Dr. Geeta certainly will be there to share her first-hand experiences. And over to you, Dr. Ravi Kumar, to introduce today's resource person. Thank you very much. Yes, Dr. Ravi. Who is Dr. Bhatt is introducing?
No, sir. Sanjit is introducing.
Yes. Thank you, sir, for your kind words. We all appreciate them. Now I'd like to invite Sahil Khan, a bright first-year MBBS student, to introduce to us our first guest speaker, Dr. Geeta Manjunath.
Maybe others can mute and let you speak.
चल दीपा आ जाओ। Sit down.
asking of books, nothing.
Ravi, what is the problem?
Ma'am, we almost done, ma'am.
If connection is problem somewhere else, you can try. No. Yeah.
Good morning, everyone. I, Sahil Khan, the student of first year MBBS, take a proud privilege to introduce our guest speaker, the founder, the CEO and CTO of Nirmay Health Analytics, Dr. Geeta Majumdar. She has led the company to develop a breakthrough AI solution for detecting early stage breast cancer in a non-invasive radiation-free manner. This marvelous achievement under her leadership has led her to be known as the data scientist who has changed the way cancer is detected through AI. After all, she's an alumni from the prestigious Indian Institute of Sciences from Bengaluru. Her 25 years of experience in IT innovation, proposing and leading multiple AI projects at Xerox Research and Hewlett-Packard India has led her to receive many national and international awards, including the CSI Gold Medal and the BIRAC Winner Award, among many others. To top that off, she's in the Forbes list of the top 20 self-made women 2020. Ma'am, we cannot express how much of an honor and a matter of pride it is to have us with you. Over to you, ma'am.
Thank you very much for your kind words. Okay, good morning, everyone, and good morning, Professor Dean, sir, the esteemed doctors. Can you hear me? Okay. Esteemed doctors, aspiring doctors. In fact, I should let you know that my daughter is also studying medicine, so I know how it is and how hardworking you all should have been to be able to attend this attend this session and also participate and continue in this education. So again, thank you so much to AVMC professors, doctors, and the innovation panel for inviting me for this inaugural, the first talk in the series of impact talks. As was introduced, I'm the founder and CEO of Nirmay Health Analytics, which is a startup I started 5.5 years ago. It's a startup based out of Bangalore. Of course, before that, I was a lab director heading artificial intelligence research for India. Because one of my two close family members got detected with breast cancer and they died within 1 year. I said, something needs to be done and started doing research in this area. And after doing 1 year of research in the late night, evenings, and so on, I decided to quit my job and do this startup because I feel this problem needs to be solved. As Dean sir also mentioned, right, it's a very, very important problem to be solved, which is breast cancer. Now, what I'll do is take you through a little bit of introduction about medical imaging, how AI makes a difference, and then deep dive into the innovation in breast cancer using AI that I spent last 6 years on. And happy to answer any questions. I think because of the large audience, it makes sense to hold your question. I will pause in between the full talk, and please, there is a raise hand button in Zoom. If you're attending on Zoom, you can say raise hand in the reactions panel, and I'll be happy to take your questions on that. So let's dive straight away. What is artificial intelligence? Artificial intelligence is about making database decisions, a computer making database decisions, a computer trying to model how humans make decisions and trying to mimic that with lots and lots of data. Just to give a very, very simple example, when a baby is growing, how would you teach the baby to recognize dogs, cats, cars, vans, train, aeroplane, or whatever, right? So the way you do it is you'll show pictures of cars, dogs, and then say this is a dog, this is a cat, and then you show real images of cats and dogs and vans and cars, and then say this is car and whatever, right? Mind you, each of these pictures that you're showing are not exactly the same cat picture. Unlike, for example, if you're showing the picture of, or let's say Narendra Modi ji, it may be the same person being shown. But when you try to teach a... Hello, is there a question? Can you all mute yourself, please? Yeah, so if you're, trying to recognize a cat or a dog, you show different cats and dogs pictures so that a pattern can be built in. Can somebody, one of the hosts, mute people who are not muted?
I am muted.
Can continue, madam.
Yeah. Sure. So if somebody needs to be muted, kindly do so. Okay, so basically what I was saying was you actually show the baby multiple cats and dogs pictures, and then the baby starts creating some kind of a pattern of how a cat looks like, a pattern of how a dog looks like. And next time you show a new cat, which is sitting in a different position, the baby is able to recognize, It's phenomenal because there can be so many varieties in which a cat or a dog can come in, so many types and all, and even vehicles, cars, for example. There's so many varieties, right? But still all of it is a car, and the baby is able to recognize it. And that's exactly the process of creating a model which is based on artificial intelligence. We show, as a computer scientist, I have a PhD in computer science was recognized. So what we've developed is in AI to show different instances of, let's say, cancer patients, non-cancer patients, and tell the computer that this is cancer patient, that is not cancer patient. And the computer now starts building a mathematical model in their mind, in the memory, in the computer, to actually be able to detect another person when the person comes in, to guess or to estimate whether that person has cancer or not. So it's a new field of computer science. I would say new, but but last 30 years it has been evolving. And so the basic thing is trying to mimic how a decision is made, how a learning is done in the human being into a computer with lots and lots of training with real data and the decision, that is cancer or no cancer. So anyway, so that's sort of, briefly what artificial intelligence means, and we can go into a lot of, I can give hours of lectures on it. But moving on to medical imaging, where, all of you are very familiar with these X-rays, the MRIs, the, CT scans and so on. These are, of course, medical images, and then these are taken through sophisticated equipment. This also has a lot of computers built in, by the way, right? So really now healthcare is becoming a merger of computer science and medical, right? So anyway, so there's a lot of these equipments. We try to look into the body. Why is that needed? If you want to find out if somebody has cancer or not, the best thing is pathology, right? You need to take out the cells and then see if there are cancer cells. But where do you take the cells out of? Which part of the body? Do you go and poke every person? Obviously, it's not at all feasible. And that's where medical imaging helps a lot. With medical imaging, what it is trying to do is to look at inside the body through different signals. It could be X-ray looking at structural, the density of the body. That, for example, a bone will look white and rest will look black and so on and so forth. In ultrasound, you're looking at tissue textural differences. An MRI is looking at magnetic resonance. So how the number of watery, the liquidy elements are coming. So of course, there are experts here in radiology, and I'm not going to go into it. But basically, different type of wavelengths in the electromagnetic spectrum are giving different aspects of the body, within the body, without invading it, right? So it's really a non-invasive way of looking into the body to identify potential areas of abnormalities. And then of course, you can do a tissue test or an FNAC or a biopsy to figure out if it is really cancer, the final diagnosis, and the treatment starts. Okay. So that is why it's very, very important to study medical imaging, because you need to first make a non-invasive way of looking into the body to identify potential areas of concern. And then it's almost like filtering out different parts of the body, filtering out different people who need not be invaded. Screening diagnosis is something that we usually talk about. Now, where does AI come in, right? And all of you know that radiology is one of the main wings where these kinds of medical images are interpreted by experts who are trained with multiple types of data and use cases that they are studied and trained and analyzed and so on. What happens is that I was in National Imaging and Radiology Conference, and I had the privilege of giving a keynote in the IRIA, which had 18,000 radiologists. Yes, there are only 18,000 radiologists in the whole of India. And there is a global shortage because we know what is the population, right? So if there is a way of using a tool based on, let's say, artificial intelligence to identify people who require the expert's attention, most people can be screened with computer-based analysis, and people who are on the boundary or looking abnormal can be sent to the radiologist. Then there is a best use of the limited experience and expertise that we have in the country. It also enhances the productivity, because if AI could actually mark the potential areas of abnormality, then the radiologist can zoom in and then make a call whether the computer is right or wrong. You can actually look up, and there are umpteen number of papers talking about errors in diagnosis, because everybody is human, and it's such a complex task of looking at images of multiple types of images of particular type of organ and then trying to guess whether the inside organ has a cancer or not. So it already obviously results in some level of inaccuracies, which can be abbreviated if you use artificial intelligence based, and hence lower the rate of misdiagnosis, enable early intervention. And finally, all of us are here to make the world healthier, right? So improved patient outcomes is there. Incidentally, I talked about the cats and dogs and all of that earlier, and that is all about patterns. And radiology and medical imaging is all also about patterns. So that is where both of them meet, right? Artificial intelligence loves visual patterns, and radiology and medical imaging and interpretation is all about patterns. So that is where, this merger or this intersection of AI and radiology has become a tremendous future potential for healthcare to enable affordable and accessible healthcare for everyone, both the haves and the have-nots. That's a really, really doable thing. So what we're going to do is to look at one particular disease that we try to solve using medical imaging and AI, and that is breast cancer. Breast cancer is the leading cause of cancer deaths. 684,000 women died in 2020 because of this disease, and 2021 numbers are much larger. It is also the leading cause of cancer incidences. 28% of all cancers happen to be breast cancer across everyone, not just women. Of course, in women, it is also a similar number. Nobody needs to die of breast cancer. We have so many doctors in this room. Breast cancer is curable. Once cured, many of us would have met, right? Women who have completed a surgery and lived for 30, 40 years. Yes, a person can have a normal life after a cancer surgery, particularly breast cancer. However, we are still losing 684,000, and India number is 96,000. Every alternate lady detected with breast cancer is dying today in India, which is pathetic. And the reason for that is late detection. People wait till they can feel a lump, palpability of a lump is 25 millimeters or 20 millimeters. And only then she comes to a doctor for some diagnosis or detection. And that initial detection is also hand examination, which again is palpability of a lump. Looking for symptoms is, yes, detection, but it's not screening. What you want to do is asymptomatic. right? We know we've all learned about how COVID has been treated, right? As early you are able to detect, you can save people from going to the ICU, right? And things like that. So early detection is very key. A little bit more before I go into how and what is wrong with the early detection techniques today and why is innovation necessary. So here is a world map showing the top cancer. Breast cancer is the top cancer in 159 countries. In the others, where you're seeing orange, all the pink is breast cancer is being the top. All the orange is cervical cancer being the top. And in all the orange, breast cancer is the second top. So that is the scene we're talking about. So it's a very important problem to be solved. We already talk about every alternate lady detected with breast cancer dying. So here you have another view of it. Every 3 minutes, a lady is diagnosed with breast cancer in India. Every 6 minutes, by the time I started, now it's almost 12 minutes, 2 people have died of breast cancer. It is really, really a big problem. How can we reduce this number of women dying? Another interesting statistics, which definitely we need to look at is the age at which the cancer is affecting women. 25 years back, it was mainly in 50 to 60 years and 60 plus years, the blue color bar. The red color bar is present is actually 5 years, but even now it's even worse. You're seeing a lot of women, even 40 to 50 and 30 to 50. In fact, I have found a 17-year-old cancer, many 20 to 30 and 30 to 40 years. It is known that the mean age for breast cancer in India is 10 years younger than the global average. We can debate on what is the cause, the stress, the food habits and non-exercise. You can talk about a lot of those, right? But yes, this is the problem. Now, this is not just a problem of India. We talked about 159 countries. If you look at the mortality rate, there's also a lot of divergence because of the facilities available in different countries. If you look at countries like Australia, US and all, the survival rate is, what you're seeing is mortality rate. So survival rate is 100 minus mortality rate. So survival rate is about 85%, which is pretty good. Whereas in countries in Fiji, it is known to be the lowest, which is survival rate is 39%, mortality rate being 61%. So it's a huge problem. So many of these countries, which of course has India also somewhere here, right? So all of these countries are not able to provide the facility that some of these countries are providing. So one is a limitation in the affordability and accessibility of current techniques to these countries. Second, even why do we need 15%? Why do we lose 15 to 20% of the women? So there are lots of gaps in the current screening method. As Sir was mentioning, mammography is the default standard. But trust me, mammography is not affordable to thousands of countries. Need not trust me, you saw the statistics. It is not affordable, it is not feasible to so many countries, including India. There are several papers written about why mammography is not feasible for India at a large scale. For every person to go through, every alternate year or every year, like in the US, every alternate year, every person is given free mammographic screening, every person above 45 years. Why 45 years? You see two mammograms here. One is a 60-year-old, another is a 40-year-old. This is mammogram, which is X-ray of the breast. The breast is pulled into between two plates and compressed to actually pass X-rays. And as we know, right, in an X-ray, anything that is dense comes out white. And so that's what you're seeing here. What happens in a 40-year-old is the whole breast appears white because it is a dense tissue. There are more fibroglandular tissues there which appear white. And here, how do you find a lesion which is white? Because obviously lesions could be white, right? Because it is dense. So the basic physics of identifying breast cancer in mammography is to find density differences, and that does not work on women with dense breasts. Because of this, several women, almost 25% of the deaths in breast cancer are happening in women under 45 years of age around the world. Also, we talked about affordability and accessibility, where even for above 45, women are not able to access a mammogram which costs 80 lakh rupees, or a 3D tomosynthesis which costs 2.5 crore, how many hospitals will be able to get this? And it's not just under 45, even women above 45 have dense breasts. 50% of them have dense breasts. Last but not the least, there is radiation exposure. How can you use X-rays to find cancer? Because every scan is slightly increasing the risk to cancer of the lady. And of course, it's not my statement. There are papers from Stanford saying how regular screening every year with mammogram can increase the risk by double for 10 years when it's done. And that's why, let's say in UK, they've changed the rule that it is once in 3 years that a lady is given a mammogram. It's not that nobody gets cancer in between. There are several interval cancers. 9,000 women died in UK because of interval cancer, so it's all about risk versus benefit if you start using radiation-based screening. So what am I talking about? What I am talking about is a possible innovation which can work without radiation, a possible innovation which can be less painful, a possible innovation which can be affordable, accessible, and finally a possible innovation which can work on women under 45, younger women, or even women with dense breasts. Is it possible? Yes, and that's what I'm going to talk about. Because today, 90% of the ladies are detecting their cancer by hand. First thing we wanted to solve was, can we detect the cancer before a lump is felt? Yes. The technology I'm talking about is called Miramai Thermalytics, which is some research that we started 6.5 years ago, and now it's used by thousands of people. It is a combination of a different type of imaging called thermal imaging and artificial intelligence. We do not use X-rays. We just measure temperature on the skin. We measured this temperature using a thermal sensor or an infrared camera that you would have seen for COVID screening in airports and so on. It's exactly similar, but a slightly higher resolution thermal camera is used. And the size of this is very, very small. As you can see, this is the image of a thermal camera, and this is an image of the breast taken through a thermal camera. I'll talk a lot more about this, but this particular solution of the combination of AI and thermal imaging has detected cancers as small as 4 millimeters, as opposed to a hand which detects 25. It's completely non-contact, non-invasive. The lady is sitting, as you can see in the schematic below, the lady is sitting in front of the device, 3 feet from the person. Nobody is touching her. There is no compression. There's no radiation because it's just measuring temperature. And the technician is outside the room. No see, no touch. And women really love it because it's such a private activity. They are very comfortable taking this test as opposed to some technician pulling it, putting between 2 plates and so on, which happens in X-ray mammography. It works for women of all ages. We've tested it and we have high level of accuracies. And if their time permits, I'll go through gory details of these studies. And 95% accuracy, even in women under 45 years of age. And across all age groups, it's more than that. I'm going to talk about it. And it can work on men too, because men also can get breast cancer. 1 in 1,000 men can get breast cancer. However, of course, 1 in 8 if you're looking at US, or 1 in 25 if you're looking at India, can get, in women, can get breast cancer. It's much, much more affordable. The device itself is 1/15 the cost of a mammography machine. If a good mammogram machine is 80 lakhs, this is 8 lakhs. So many, many diagnostic centers and hospitals can afford it. And because of the AI, there is automated interpretation, which of course, I'll talk about it. The report actually can go to a radiologist for detailed analysis and diagnosis. It's a portable device. What you're seeing is a photograph of the image and of the camera and the laptop. So it's a very, very small device, the size of a water bottle. You can put it in a backpack and take it out to do rural screening, corporate screening, apartment screenings, right? Screenings in apartments. And also we've started private screening at home screening, like home COVID test, right? It's possible. Because of this, early detection is definitely possible. We did a large, took one particular district in Kalburgi district, one particular taluk there, and screened in the last 5 months, screened about 3,600 people. Beautiful. So many people came in. 97.8% of them had never ever had a breast screening. Even a hand examination had never been done to them. So it's really possible using this test to address thousands and millions of people who have never ever had breast cancer screening, because it is no see, no touch, no radiation, no pain, and works for women of all ages. Now, let me go into details of how this works, and then I'll give a pause for your questions. So just quickly, we call this technology also as thermalytics, thermal analytics. As I mentioned, we use a thermal sensor. Any off-the-shelf thermal camera which satisfies the specification that we give, like 320 by 480 and so on and so forth, can be used to measure the temperature. All of us have had an infrared thermal scanner taking your temperature of your forehead or hand or in many places, right? That's a single point. That is an infrared thermal sensor, but it takes one temperature point. What I'm talking about is an array of thermal sensors, which takes 400,000, 4 lakh temperature points per person. We keep that device, take a click, take 4 lakh temperature points, and what you're seeing here is a heat map of the temperature distribution. A white color is 37 degrees Celsius, red color could be 36 degrees Celsius, or yellow is 35 degrees and so on. Just giving an example. So what you're seeing is a temperature shown in color. So what happens if there are temperature differences, you'll see in a color difference. And that is how people earlier, or small 500 doctors in the whole world, roughly, are using this for detecting breast cancer, because they look at the color differences and say, there's something wrong in the left breast versus right breast. But then there are several reasons why a temperature difference can happen, not just for cancer. So that is where they are erring, and they had to use other methods. So it's an adjunct modality and all that. But when you add machine intelligence, when you add artificial intelligence, when you add database decision making, then what we have shown is that it becomes very accurate. We're able to mark the exact possible location of breast cancer, estimated, so that a follow-up diagnostic workup can be done with an ultrasound or an MRI. And of course, a radiologist is needed to do the final diagnosis, and then the tissue test, a pathologist is needed, right? So this is very unique. This is definitely innovative, because just in the analysis of these thermal images, so basically converting a temperature distribution to a breast cancer screening report is what thermalytics is trying to do. And just that has resulted in 27 international granted patents for Niramine. And 11 of them are US granted patents. And you'll hear people talk about one granted patent. I'm talking about 11 granted patents just in this solution from US, and 12 in India, and several others in China, India, Japan, Canada, Germany, and Europe is pending. So this is definitely an innovative technology made in India for the world.
To the Niramine technology.
Here is how,
having heard about it, I went to get a checkup done.
1 second, maybe you are not able to hear sound.
I was quite skeptical before I went for the test. It took me by surprise because the machines didn't touch me. It was all happening from far away. जैसे आई टेस्ट होते हैं ना, दूर से बिल्कुल वैसा.
So as you can see, right, it's a very, very simple test. She was just sitting on a stool and turning, and the images were coming. And the technician was outside. If you notice, there was a screen that was put. So this is what is the end user experience. And it is now deployed in 120 plus hospitals, almost many Apollo clinics, HCG, Max, and several other hospitals. I just brought out 3. And as I mentioned, you can do the screening in any place. This is, in a hospital, they just put this way also we can do it, or, corporate camp, I think this is, they put a, small makeshift room kind of thing. Technician is outside and she's inside. We have a bus funded by Rotary called Pink Express, which Sakra Ward Hospital runs, which has a small room just near my test. And this is private screening. So this is not just in India, it's already operational, actually not pilots, operational in Kenya, Turkey, Greece, and we've started pilots in UK, US, basically Texas, Newark, and other places. This is very, very unique, computer-aided diagnostics using artificial intelligence and machine learning. Maybe I'll pause for a while and see if there are any questions before I get into more details of the solution, assuming I have half an hour more. Any questions from students or professors? Please unmute yourself before asking the question.
Madam, I am
Yes.
Dr. Nagapan here.
Yes, sir.
Yeah, it's a wonderful technology.
Thank you, sir.
Congratulations to you, madam, for such a big innovation.
Thank you, sir.
And some 2-3 questions are there from this. Whether this thermalytics will diagnose micro calcification masses together?
Yes, sir. So it's a very good question, sir. So you will agree that microcalcification is not equal to cancer. Sir, it's early detection of cancer, but there are, out of all the microcalcifications found, 10% of them are only malignant. 90% are benign. What happens is mammography says microcalcifications, by an ultrasound is done. Ultrasound may say it is benign, or maybe sometimes biopsy is done, by biopsy may say benign. So if a microcalcification is found, about 10%, less than 10% are actually ending up requiring a treatment. So what happens in this case is, this is a physiological analysis. So we have found malignant microcalcifications. However, benign microcalcifications may not be identified here because there may not be activity, there may not be a vascularity around it. So it reduces the false positive rate because of benign microcalcifications also. So, but yes, because we are able to detect 4 millimeters and 5 millimeters of cancer, I mean, like I have 2-3 patients in both these ranges. Definitely, we have been, in fact, we did a study on just microcalcifications and, benign and, what mammography detected and this, and we did find, all the malignant microcalcifications were detected.
Why this question came to my mind means because, the present generation ladies, I'm not just finding fault on them. Because of their workload, they cannot able to give the breastfeeding as our mothers and grandmothers gave.
Absolutely.
So because of the breastfeeding is arrested somewhere, not given, these microcalcifications masses benign can become malignant. One of the studies says. That is my concern, madam.
Absolutely, sir. Absolutely, sir. So you're absolutely right. So of course, we talk about breastfeeding. In fact, to do the machine learning model, we asked, did the lady have any breastfed children? So we take that also into consideration, not just the thermal image, and I'll little bit talk about it. It also takes other breast cancer risk conditions so that, we can give a holistic outcome of what is needed for the person. And you're very much right. A microcalcification or a blocking or in the milk duct can actually lead to cancer later. So what we have done is to give a score, basically. So when a person comes in and does a scan, a report is generated with scores, just like a person takes a sugar test, right? Glucose reading is given 120, 150, 200, whatever, right? And this score is what you monitor. Obviously, you want to keep it under the limits. So like that, we have a breast health score, a set of scores. And so if a young girl wants to do the screening today, every year she does, and she keeps track of this score, right? And if she had a microcalcification, if she had a blockage, instead of having a 0 score, she would have, let's say, 0.3, 0.4, and then she has to keep track and make sure, her, if possible, lifestyle can be changed to actually stay healthy, or of course, keep watching in case it becomes malignant and turns malignant, and then appropriate treatment can be done. Of course, we can have people like Angelina Jolie, right? Who kind of, can take proactive issues. So a proactive removal, I mean, that's too much. I think it's over treatment, but yeah, it's up to the lady to make the right call on that front, sir, based on the scores. Very good question, sir. Thank you for that.
Thank you, madam. Thank you, madam. I'll be in touch with you. I'll be getting the your phone number and mail ID from Pushpa, madam.
Sure, sure, sir. Sure. Thank you, sir.
One question here.
Yes, sir.
See the temperature difference you are measuring because of maybe metabolic activity.
Yes, sir.
So does this machine differentiate infection and malignancy, or you have to examine or see the biopsy or that type of thing?
Very good question again, sir. You're right. Sometimes, we have abscess, which are really big infection inside coming out as high thermal activity, focal thermal activity. And what we see is we see it as a hot spot, we call it, right? That's the term we use. Then we look at the structure of the hotspot. Sometimes, the infection and inflammation would be more rounded in nature, because what happens in the metabolism created because of cancer is that there is more irregularity, as we know, right? The mitotic activity is really erratic and irregular. So you'll see irregular boundary. Having said that, there can be false positives, which are because of abscess and infection. Definitely, I will not rule out that. There are cases using the structure of the hotspot, we are able to say whether it is cancer or like benign could be inflammation. But there can be some confusion, and sometimes you may say it is positive, but it can be abscess, right? And that's why we do not recommend direct treatment after this. After this, there's an ultrasound, which can typically differentiate between an abscess and, of course, an FNAC or a biopsy can be done to have that differentiation. So yes, that confusion can be there. But then many times what we have found is the lady requires an antibiotic or aspiration, some small treatment, which thankfully may not be cancer. So that still will help the lady, because this can be used for screening at this point in time. Good question, sir.
Another point.
Yes, sir.
See, all cancer cells are metabolically active.
Yes, sir.
So the temperature difference may be there in all cancers. So the same principle what you have used for breast cancer can be used for cervical cancer and other types of things.
Absolutely, sir. Absolutely, sir. Very good point again. In fact, we have a roadmap of looking at several other types of cancer. And I give an open call here. Now we have so many expert doctors on this, in this audience, as well as upcoming students, right? Because we are a small startup with 50 people, and we are focusing on breast cancer because it's a huge, humongous task to actually create a solution and take it all over the world. And we are focusing on that. Having said that, we are interested in research in enabling thermalytics for testing and clinically validating it for other type of cancers. And if any of you are interested, we'll be very, very happy to collaborate with you to do those clinical studies and publish in reputed journals. Sir. It's absolutely right, sir.
Sir, you have snatched my question.
You can ask one more question.
Actually,
no, madam, cervical cancer is your area. So
that's what it was striking me. And
definitely we'll work together, ma'am, on the cervical cancer.
Sure. Okay. And that is more, in our country, so many people, they are not only dying, but they come in all 4th stage and all. So when we see them, we really feel bad, because in spite of our awareness program, in spite of repeated telling, they don't like to get pap smear done.
Yes.
So something non-invasive will definitely work here.
Sure,
in fact, I was thinking the same thing in that direction, whether cervical cancer we can diagnose with.
Absolutely.
Cervical, uterine, ovary.
Uterine, yes.
Yeah.
But this is a very severe problem, cervical cancer.
Yes, it's a second top cancer. That's what, ma'am, I was showing the world. So it's always in top 2. In some countries it is top, some countries here in India it was highest, and thanks to some of the programs it's now become the second top. But definitely, ma'am, we will look at that as one of the collaborative opportunities. Thank you so much for that.
But if we look at it, it is a problem of rural area and slum area people who are illiterate. Yes. Nowadays, breast cancer is more common in people who are of hi-fi societies and all.
We have actually found cancers even in rural areas. But you're right, ma'am. This type of method, which is portable, radiation free, can be taken to rural areas to do the cervical scan, where cervical cancer is more. Absolutely right, ma'am.
So I have to congratulate you that you have done such a tremendous
thank you.
Work within about 5 years.
Thank you so much, ma'am. I will go into more details of a little bit of this, given that we have so many upcoming doctors and aspiring doctors, and of course, expert doctors already in the audience. So there is AI. Where is AI? Just using thermal images, we can detect some with visual, but we miss a lot. If you Google thermography, that is what it's called, just using visual analysis. And that has a lot of falsity. it has misses many cancers, and because it's very, very hard to look at 4 lakh temperature points in color. Some of you were old enough, you'll remember Mera Wala yellow, Asian Paints used to say there's so many shades of yellow, so many shades of orange. How do you know? Instead of that, the computer is now looking at 26 degrees Celsius, 26.02 degrees Celsius, separate points. So because it is looking at individual temperature points, not necessarily the color, it's able to do more fine-grained analysis, which is computer-aided diagnostics and detection using AI. So there are 2 types of reports that we generate. One, like ma'am was saying, in rural areas, when you take, these things have to be very, very, fast and can be used for cervical or breast, but we give automated red, yellow, green, because it's difficult to find radiologists. We are doing it in rural areas. When you're doing a screening of 1,000 people, 100 people, right? Immediately you have to give the result. If you don't give the result immediately, then what happens? The lady goes back home, and it's not even possible to, trace her, because her address will be next to Ganesha temple, like that. You can't even figure out. We had a village camp where there were 2 Sharadammas. It took so much time to go and trace which Sharadamma was actually red and which one was green, right? So but if you actually do it immediately, then you talk to their family members, take them to the hospital immediately and get the final diagnosis. And of course, treatment will start further on later. And then we also have a second one, which is used mainly in urban areas, diagnostic centers, hospitals, where a full detailed 3-page report is given with annotated images marking the area of potential malignancy. So of course, this goes automatically to a radiologist, which is configured on the system for the hospital, and the radiologist reviews this along with any other reports that are there to give a final diagnostic observation. And for those of you who are engineers in this audience, you may want to know a little bit more inside what is happening. So what we do is, you saw the video, right? We are taking 5 views, like the lady is rotating on a stool, because we take lateral and oblique views, that is 45 degrees and 90 degrees left and right similarly, and frontal. So 5 views: frontal, left 45, left 90, right 45, right 90. And with these 5 views are uploaded by a technician. Technician can be a simple health worker or a nursing staff. She takes these images without seeing the patient, she uploads it. Inside, this is just a black box opened up, like the onion peeled out, right? This is happening in the cloud. So first and foremost, we look for quality of images, whether she has taken in the right angle or not. If not, immediately we'll tell the technician, hey, you're not taken properly, take it again. So the technician is right in front of the patient, she can redo it, because that's the way you kind of, train like fresh technicians. And then all the rest of the checks. 10 minutes of cool air is blown on the person, which is part of the overall protocol. And then 2 minutes of imaging and 2 minutes. The whole thing will be done within 15 minutes, right? A full, analysis, report, screening, everything will be done within 15 minutes. Then these images, which are high quality, are going into a next called image segmentation. It's called ROI segmentation, region of interest segmentation. So we kind of identify the breast region from the image. And also we have a new method of identifying vascularity, blood vessel structures, right? Because if there is a deep tumor closer to the chest wall, you may not be able to see the hot spot or an increase in temperature on the skin, because we are measuring the skin temperature. So what we do is mark up the vessel structure. So because as we know, right, the blood vessels in the epidermis is feeding to the tumor, and the tumor is actually taking more and more, blood. Basically, blood flow to the tumor is higher. So there's vasodilation, neoangiogenesis, and so on and so forth. All that results in a different pattern of blood vessels in the breast, which is affected versus another one. Even for deep tumor, the blood vessel asimilarity gives you a good enough hint. And that's where the vessel segmentation helps. It's a different patented algorithm to extract blood vessels from thermal images. And then several other techniques are used. 117 different thermal features are extracted. And all of them go into machine learning, what we call as classifiers. These are classifiers or machine learning models which are able to say one versus another, class 1 versus class 2, cancer versus no cancer. This is what they actually compute is probability of cancer, probability of malignancy. So 3 classifiers are used so that we can explain the result. If the tool is saying it's cancer, we have to know whether it's because of increase in temperature or it could be an inflammation, as one of the doctors was mentioning. Or is it because of vascular asymmetry, right? Because then we know maybe there is a cyst also. So you're able to guess If there is a false positive, you know why that could happen. And areolar, which could be a milk duct issue. And then we have an ensemble, which means taking all of it together along with complaints, patient complaints, lump. For example, if there is a lump in a particular area, we superimpose a thermal signature and say, is that a hot lump or a warm lump? Using that also, we are able to guess the final Biret scoring. And many of you would know Biret scoring is what is used to report the status of breast health in mammography, ultrasound, or MRI. Biret 1, 2, 3, 4, 5. 4 and 5 is malignant. 1 and 2 is normal and benign. 3 is 2% malignant possibility, and so there is usually a follow-up in 6 months that is recommended. Biret 0 is inconclusive. So if we give a Biret score as an output, estimated Biret score as an output, and show it to the doctor, right, for a review before giving to the end user. So there is more, right? So some of these scores that I talked about, thermobiological score, areolar score, vascular score, these are numbers between 0 and 1. Any number greater than 0.5 is cancer. And then this is the Biret score, which I said 1 to 5. This is the same use case, but the full report is zoomed in and shown. And then the marked area in blue is where the cancer is, so that you can have a targeted ultrasound at the left breast upper inner quadrant in this particular case. This is regulatory approved. Of course, during COVID, we were pretty hit because women were not coming to the hospitals. Then we focused on regulatory clearances. So we got Europe regulatory clearance. That is, this test can be used in any country in Europe. Many countries in Asia and Africa also, it's being used. It can be used in all about that. In fact, we've got a lot of requests from Dubai, like MENA region, and several other Brazil, everywhere it's coming. But we got, this is usable because it's a CE mark. And then also 2 months ago in March, we got a US FDA clearance for one of our devices, which is able to mark the area of potential abnormality. And we have all the quality systems that is needed for a software-based analysis. The last few slides are on clinical validation. And if there's time, I can go through some use case and case studies. So
can I ask one more doubt?
Yes, sir.
This temperature which you are showing, the 23 to 35,
yes,
is not our human body temperature. So is it a conversion of something?
Yes, a very good observation. So what we do is we make the lady sit. If it is in a hospital, in an AC room kind of thing, the AC room is set to 23 degrees Celsius, right? She's preconditioned for 10 minutes, right? The 15 minutes of the test includes 10 minutes of preconditioning, 2 minutes of imaging, 2 minutes of reporting, right? So if there's an AC room, she's sitting like this for 10 minutes without her clothes. If there's no AC, like in rural areas, we blow cool air on the person. So we have a small water cooler and blue. So what happens because of this is normal body temperature, as you said, is 37 degrees Celsius. So we bring down the temperature a bit. So there is a contrast buildup. Very, very active cells are still at higher temperature. Of course, not 37, to be a little lower, but normal cells actually, respond immediately and they go back to, much lower temperature. So the contrast building happens, and then we are able to analyze it much more accurately. And that is what, that's why you see a range of temperature, which is 25, 26, 27 to 30, 37. Yes, good observation, sir. So, as many of you would know, when we do a clinical evaluation, the way we have to do it in a prospective randomized setting, we say, right? In the medical device condition, it is like observational study, we say. That is, every person comes in, takes a thermolytics test, and thermolytics gives an output result, and that is not shown to anybody. The same person goes to mammography, ultrasound, biopsy if needed, or MRI if needed, all of it, and the doctors together look at the different reports and give an observation. The comparison is done between what the automatic thermolytics tested and what is the combined evaluation of the, you can say triple test or whatever, right? So that is what is the result you say. And in healthcare, as some of you are from first year, we don't talk about accuracy. We talk about sensitivity and specificity. Sensitivity is I would say roughly accuracy in positive patients. Specificity is accuracy in negative patients, roughly I'm saying, right? And it's a true positive by, true positive plus false negative, and so on and so forth. We can talk about different aspects of sensitivity and specificity. So sensitivity will tell you how many of the actual positives have been detected. So it is actually identified positives divided by true positives, right? And so touch wood, we have so far not missed any cancer that has been detected by either a mammogram or an ultrasound or an MRI in asymptomatic women. In symptomatic women, which is basically a diagnostic workup, where definitely, when you compare with biopsy, it is 90% sensitive today, right? Because there could be nipple discharge, which can reduce the temperature and so on and so forth. So if there is a symptomatic person, it is 90% accurate. If it is like general screening population, it's 100%. And of course, there will be false positive rate. There are about 7.6% false positive rate, which is 100 minus specificity. And this is not something like a lab test where we have done. This is a systematic multi-site study, which is done between HCG Bangalore and Narayana. We are based out of Bangalore. And American Society of Clinical Oncology has several journals, and JCBO Global Oncology, Journal of Clinical Oncology, is one of the top journals. And this was peer reviewed by multiple experts and published eventually. And you may wonder, how does it compare with mammography? And here it is. What is 100% here? This is a different study on 769 patients. What is 100% is 67% in mammography. And yes, there are several cases in breast which are missed by mammogram, and I'll show you some examples. And this was termed as a breakthrough top 50 ideas by ASCO, and we were given like to and fro travel and grant and all of that to come and present in this 2019 October. It was held in Thailand. So that, of course, false positive rate is much lower. That's a nice thing. That's why it's great for diagnostic workup. Whereas screening, where you do not want to miss any cancers, Thermalytics is very, very good. To see why that is so, right? We have two cases here, and we may have radiologists here, and they will know that these two are dense breasts or heterogeneously dense. This is heterogeneously dense breast, and it's very difficult to figure out where is the mass, right? There doesn't seem to be any mass here. There seems to be some abnormality, some irregularity here, but it turns out that there's no cancer here and there is cancer here. And when you do a thermalytics, you know very clearly there's a huge blob in the right breast, upper quadrant, right, which was finally confirmed by MRI and biopsy. And here, though it looks slightly asymmetrical, you will see that it was marked in green, means it's a benign hotspot. And yes, it was just a cyst when it was observed in ultrasound. So like that, we've done several studies in dense breast also where we found a high level of sensitivity, and this was done in Max Healthcare. Several such papers have been published for breast cancer. And I'm happy if you can just Google Thermalytics or kind of our name in PubMed, you will see many more as well. So I had I had several other things. I can take some, maybe quickly flash some use cases because this is the next level deep dive for doctors and doctor-to-bes. And so you have these 5 views of the thermal image: frontal, left lateral, left oblique, right lateral, right oblique. And there is one, I'm going to show one malignant subject, one benign, and one normal subject. So here's a malignant subject where we mark in blue color, and the mammo and ultrasound clearly said large, ill-defined, irregular mass, right? In central and upper quadrants, you see central and upper quadrants on the right breast, exactly what was found. And the mass here was huge, 5 centimeter almost, it's a huge one. That's why you see from here to here, the marking is there. And you see in the vascularity that there is a feeding blood vessel that's coming. And obviously it was Barrett's 5, highly suggestive of malignancy, which was finally histopathology correlated and the lady was sent for treatment. Here is a case where there's a lot of abnormality. It looks like abnormal in just when you do a visual analysis, a lot of orange, red. But when Thermalytics was used, it marked these 3 parts. I don't know whether you can see there are 3 small green things here. Those were marked, not in blue. Blue is cancer. In our terminology, green is benign. So 3 green things were marked. And incidentally, when an ultrasound and mammogram were together done, and that's what usually most hospital does. I don't know what your hospital does, but usually most women do both because mammogram is not accurate. They actually have ultrasound as well. Now, so this was also a benign, condition as per even mammogram and ultrasound. And you'll see that at 2 o'clock position, they actually saw a large cyst. This is the 2 o'clock position on the left breast, where there were 2 cysts that were found here as well. Few cysts showing internal echoes. Yes, that was what the benign thing. So you can see the correlation of the location as well. And here is a normal patient. There is no marking, nothing. And this was also unremarkable in mammo and sono as well, right? So these are 3 conditions. So let me take some more examples. The first column you're seeing is the Byrod's scoring from the thermal, and the second column, basically second is what thermolytics said, third is what mammography and ultrasound said, and the first one is images. So here is again a Byrod's 5, confirmed Byrod's 5. Here is a Byrod's 1, confirmed Byrod's 1. And then here is with the NAPSIS, and I think doctor was mentioning before, right? This is a very, very highly neoplastic, with a high thermobiological score of 0.9. But what happens is even areola score is high. So that's why it's not just inflammation, there is malignancy as well, right? Thermobiological score can be high for inflammation as well as for cancer, whereas these things will not be high for inflammation. So that's another way of looking at it. Then there's a benign condition with, just vascularity, nose symptoms. Right, so that is, you'll see that the similar retroareolar region, there was an issue that was found. This is another case, ensemble being 0.69, there was a lump and it was overlapping with the thermal abnormality, and hence it was called as malignant. And again, it was a 4C, it's not 5, right? Which was again suggested for histopath correlation. So like that, I can actually share many, many examples. And holistically, if you look at where will thermolytics stake, right, it definitely has higher accuracy than mammography. MRI is great, high sensitivity, and we all know specificity of MRI is lower. Ultrasound is great, but it is very subjective, and it is great if you have a targeted location. If you have a lump, figuring out whether it is, malignant or what kind of tissue exists there is excellent in ultrasound. But if there is no lump, it's very hard for all radiologists to find. There's a lot of papers talking about subjectivity of ultrasound, but targeted ultrasound is excellent. So you can do a thermolytics, find the target and do an ultrasound, and then of course ultrasound guided biopsy if required. So that's the accurate affordable screening. That's one space where nothing was there, and thermolytics can enable this, to enable large number of women who have been missed, who have not been able to screen with breast cancer, not just for accuracy and affordability. As we talked about, it's no touch, no see, no pain, no radiation, and that also makes it more comfortable for 1.8 billion women who have not screened for breast cancer ever on this world. This because like many of the doctors also commented, it's a very innovative thing, and we've been, initially we didn't know. I just jumped off thinking that it requires to be researched, but we have received a lot of awards. Recently, we got, it's not here, a Commonwealth Digital Health Award. Commonwealth is, as you know, hundreds of countries, all of them. This is from India alone, right? There's thousands of startups applied, and we got the Commonwealth Digital Health Award. We got the World Bank Women Health Tech Award in Las Vegas. I've met Bill Gates, sir, shook hands with him because he was very, very impressed with this, and his given as a research grant. And of course, Modi ji's National Startup Award diagnostic category is also won by Niramai for this particular thing, and also in Japan and several other places. And so this is something that, has given us a lot of encouragement and fuel to actually continue to work on this space. And my favorite is this one, which is all the AI startups in the top 100 AI startups. And you see India is blue because of Niramai. India is the only Indian startup on the top, Niramai is the only Indian startup on the top 100 AI startups in the world. So with this, I just want to end my talk with a few call for actions. All of you are ambassadors, you're all doctors, you're going to be doctors, like doctor students. And if you want to look at breast health, please tell every lady that as many ladies as possible, as many girls as possible, how important breast health is, how important to have regular screening for breast, it is, because early detection can save lives. The survival rate for a stage 0, stage 1 is 95%. It is 5-year survival. A 5-year survival for a stage 3, stage 4 detection is 10%. So that means you can actually flip the coin. There's so many people who can live if we can do regular screening of women, right? And so one simple thing is monthly self-breast examination. At least let's look for symptoms, early symptoms, so that we can bring them to it. So we actually also give videos of how to do it. Second, using machine learning, we actually came up with online breast health test where the lady can answer a few questions, and using machine learning and artificial intelligence, it generates low risk, moderate risk, medium. This is a free service we have provided. Any person can go to niramai.com and assess her health, breast health, and get these 4. And then if she's it's also now available in WhatsApp, right? We have this WhatsApp number 94834 34444. 94834 34444. If anybody can give, this is a breast health helpline, again free. Anyone can say hi and I have a query and give a query, and we either, if we can answer, we answer, otherwise we ask an further expert to answer this. And then we also make breast health assessment possible on this helpline. And we get normal, moderate risk, medium risk, high risk, 4 risk categories. And then based on that, we can suggest how for example, medium and high risk definitely can go for much higher level of annual screening. So which is basically, we could recommend a personalized health assessment for everyone, at least for those who are moderate and high risk. So with this few words, I would like to end my talk. Dr. Pushpa ma'am, I have ended right before 11:30. That was given as my time, and happy to take any questions in the next 2 minutes that I have. Thank you so much. I hope this was useful.
Thank you so much, Dr. Geeta.
Madam, one.
Sure.
Sir, Nagappan sir, please go ahead.
Sure, Dr. Nagappan sir.
Madam?
Yes, sir.
Yes, sir.
Madam, it is an excellent presentation and eye-opener for many of us.
Thank you, sir.
Only one thing is I am having a doubt. Breast is a conical shape. Unless otherwise it is compressed, that uniform attenuation of radiation may not happen. That is why the mammography instrument has been introduced very long years ago. And still the FFDM is going on. It is clearly giving the MLO and CC.
Yes,
but how this thermalytics is going to cover all these things is one doubt I am having.
Very good question, sir. You're absolutely right, sir. So the CC and MLO views are given at like full flatten, and that of course no lady likes it for compression.
Yeah,
but,
pain is there during mammography.
But then it goes through. So the equivalent of that is, first of all, we do 5 images, sir. So we do the left oblique, left lateral, and frontal. So there are 3 images per breast. So what we do is we combine all of it. We call image registration to create a holistic, 3D view, if you will, of the breast, right? So using that, we can make out whether, there's any abnormality. The only problem is if the lesion is very close to the chest wall and it's a very big breast, right? Then there's so much flesh, then we may not be able to see the thermal signature. That is where we use vascularity, sir. For a big breast with vascularity being asymmetrical. Yes, which is very close to very deep tumor only. Otherwise, we are able to detect even without. So vascularity, combination of 3 views, we are able to detect even deep tumors, sir. Very good question, sir. Thank you, sir.
I took the problem of pain and I devised my own equipment and I got patented for that, madam.
Oh, we'd love to talk about this, sir. So
yeah, I have to make it as a product now. I have already got that. That we will discuss, madam.
We can discuss, sir. We can discuss.
We have to create a lot of awareness among women, as you said. And monthly screening is much important. Yours is portable. Why cannot you go door to door? That is much needed because women becomes very shy to come out for screening.
Absolutely, sir. So exactly. Of course, we are partnering with people who can actually take it to door. Having said that, we have done 57,000 screenings now. Of course, in 2 years in COVID, we could not do. Last 1 year, we have done many screenings, and 1 year before the COVID, because first 2 years we spent in developing the product. So with that, we have done that private screening at home. Now, any person here also, anyone here wants to do the test, they can come to niramai.com, book an appointment at home. Our team will come and do it. Of course, it is priced also. But similarly, we have done that together, sir, like, apartments, group screening, and so on as well, where you're saying, women are hesitant to come to the hospital. So we take, like they say, we can't get the horse to the water, take the water to the horse. It is possible because it is very portable. I think there is one question from Raksha Sri. Yeah, go ahead.
Yes, ma'am. There's a question.
Thank you, madam. Thank you.
Thank you, sir. You have to unmute and ask, Rakshasri. You have raised your hand. Okay.
Rakshasri, do you have
Click
question?
the right button and say unmute and you can ask. Okay. Maybe she raised lowered. Yes.
Mm.
So any other question? Any other question in the audience? The prospective students? You can lift your hand. I can't see, but yeah, maybe. But if you have any question, I'd be happy to answer. I can see all the students. Did you like that? Can you just show your hands? Any of you like the innovation? Yeah, I see one thumbs up, 2, 3, 4. Thank you. Thank you. Thank you. Thank you for your feedback. Thank you for your feedback. So I have put my email ID in the chat. It is geeta@niramai.com, or you can just look up my name, Geeta Manjunath. I have, thankfully I've given so many media, a lot of people were interested. Videos are there, so you can watch and you can send me questions. Happy to answer. Dr. Pushpa ma'am, I think if you allow me, I'll take leave and request the next speaker to go on it. And I'm very happy to collaborate with any of you, including yourself, ma'am, for taking this solution to other type of cancers, or if you want to conduct camp in your college for the students, for the college professors, doctors, or in your hospital, if you want to install, all of that is very, very welcome, ma'am.
Sure, Dr. Geeta. Actually, I wanted to say, when you were talking about partnership,
yes,
our students are now, they are involved with Rotaract Club. We are going to have installation in this next week of our Rotaract Club. So they will learn about these techniques, and they themselves also can be involved with that.
Excellent,
So
excellent.
that is hands-on training for them.
Absolutely, absolutely. And we also have internships. Like, for example, if you want hands-on on how to, let's say, for example, several Apollo clinics are there. If you want to spend some time in the clinic, just as internship, 1 month, 2 months, 3 months, or 1 week, whatever. If you just write to us, Doctor, you can all contact Dr. Pushpa ma'am. She knows my phone number also. So you can direct them to me. Anytime we can give you camp experience or internship in diagnostic center or hospitals, very happy. And you're serving so many people. And it's very simple. I tell you, to learn how to do screening with thermolytics for you guys who are already student of doctors, medical students, it hardly takes half an hour to learn. For a technician, new health worker, we take 2 days because we want to train her properly, like 2-3 hours we teach her. But for you people, it will take only half an hour, less than half an hour to learn about how to do it. So anytime if you want to do an internship or spend time on screening programs, community camp, very, very happy to support.
And they are well versed with all these newer technologies than we old people.
No, everybody knows Facebook, and all the qualification is somebody needs to know how to do Googling on the web or mobile. That's what we say. We also have another portable, smaller device that we have built ourselves, which can be controlled with mobile phone, and you can use it for screening. It's called My3. So I will talk, we can experiment multiple things with that also. Yeah. Thank you so much. I hope this was useful, and all the best, students, for your medical profession. And thank you so much, doctors and dean professors, for careful listening and appreciating the work also, sir. Thank you so much. Thank you so much.
Thank you, Dr. Geeta. Dr. Savita is already here. I welcome Dr. Savita.
Thank you so much.
I welcome Dr. Savita. Where is our MC?
Yes, ma'am, I'm here.
He's there.
Sachin.
Yes, ma'am, I'm here.
Dr. Savita, we encourage our students to get involved with these events. So
Yes,
most of the things are actually organized by them.
Yeah, here, your team is here, ma'am. First, I'd like to thank Dr. Geeta Manjunath, ma'am, for her insightful words. I'm sure that, like me, all of us got to learn a lot from her today. As we move on with the program, I would like to invite Bharati Chandran, one of the best first-year MBBS students, to introduce to us our second guest speaker, Dr. B.A. Savita.
Would you like me to get started?
Start introducing. Voice is not heard.
Would you like me to get started?
They will just introduce you. After that, you can start.
A very happy morning to one and all gathered here. I am R. Bharati Chandran from first year MBBS, taking the honor to introduce our next guest speaker, Dr. V.A. Savita. She has been working in the laboratory director of OncoStem Diagnostics Private Limited, Bangalore. The laboratory has received renewal of accreditation from the College of American Pathologists under her leadership. She has done her MBBS, DPB, DNB in pathology. She has 16 years of vast and various experience, which includes 5 years as a laboratory director at Standalone Diagnostics Laboratory in Mumbai. She is a woman of many talents, and her strength lies in laboratory operation, manpower management, quality assurance, and professional networking. Her passion includes medical research, especially in breast cancer, and contributed to the poster presented in ASMO 2022 and the papers published in PubMed indexed journals. She is a proficient at establishing and maintaining documentations in compliance with international standard ISO 15189, NABL 112, and the College of American Pathologists. She is a certified internal auditor for ISO 15189 standards. She has been a part of national and regional CMEs and a conference which has served as faculty and conducted workshops. She has done her MBBS in Gandhi Medical College, Bhopal, Madhya Pradesh, and her postgraduate diploma in pathology and bacteriology, DPB, from Soumya Medical College and Research Center, Mumbai. She is a diplomate of National Board in Pathology from National Board of Examinations. Ma'am, your works and achievements are really fascinating us. We are really delighted and overwhelmed to have you with us today. Over to you, ma'am.
Thank you so much for the very kind introduction. And at the outset, I'd like to say a very good morning. And it's no, easy task to follow on Dr. Geeta Manjunath's excellent presentation. And I am really thankful to AVMC Pondicherry Medical College Innovation Council for offering me this opportunity of sharing my thoughts and our innovative solutions from OncoStem Diagnostics. I would be talking about again, the theme is of breast cancer, and we'll be talking about our problems and our innovative solutions. Are you able to see my slide?
Yes, ma'am.
Okay. It should be put on, correct.
Yeah. So I think as Dr. Geeta has already spoken, we know that breast cancer is one of the leading cancers in women, not only in the world, but also in India. And worldwide, 2.5 million women are diagnosed with breast cancer. This includes around 900,000 patients who are diagnosed with early stage breast cancer. India itself has got tremendous numbers, especially in urban areas. Breast cancer remains to be one of the commonest cancers, and in 180,000 women are diagnosed with breast cancer, with 65,000 women who are diagnosed with early stage breast cancer. So we can see that it's a humongous problem that we face here. And whenever we think of breast cancer patients and how they get treated, this is the image that comes into our mind. We think of a woman who has undergone surgery, chemotherapy, and the question is chemotherapy required for all the patients? Here, I'd like to say that cancer treatment typically it starts with the diagnosis and proceeds to the surgery in which the primary breast cancer tissue is removed. Subsequently, the woman has to undergo radiation and chemotherapy. However, it is not one size fits all. Every patient does not benefit with the same multimodal type of treatment. It has been well known that chemotherapy benefits only 15 out of 100 women actually benefit or require chemotherapy. However, Indian statistics are 95% of patients of EBC, that is the early breast cancer, which is stage 1, stage 2, and stage 3A breast cancers, they are subjected to chemotherapy, whereas only 15% benefit from it. This overuse of chemotherapy leads to physiological and also financial toxicity. Western prognostic tests have been in the market for almost around 15 plus years. However, these are neither affordable nor suitable for patients in India. So what is the solution? Our innovative solution is OncoStem Diagnostics has developed a quick, reliable, and cost-effective prognostic test for breast cancer patients. So this CanAssist breast, which is the flagship product, it is done of FFP blocks, which is the formalin fixed paraffin embedded tissue blocks, which contain tumor tissue. These are taken from patients, and risk of recurrence is given to the physician within few days post surgery. And the doctors use this information to customize the patient's post-surgical treatment. Outcome is improved quality of life for patients and also substantially lower cost of treatment of the cancer itself. So coming to, just give me a second, please. Yeah. So coming to what is personalized medicine. So typically what happens is there is this group of patients. If everybody is given the same treatment, there are some who benefit, some who do not benefit, but they are receiving that therapy anyway, which may sometimes have some serious adverse effects. So there is a group of patients who are not benefiting, but who are who have to face the adverse effects. However, with personalized medicine, each patient receives the right medicine for them. So there are these patients who undergo some kind of biomarker diagnostics, and this biomarker diagnostics helps in choosing the right treatment. So the patients get the treatment which is right for them, so that the adverse effects and benefits both are in the favor of the patient. The patient can be treated way better. So coming to the Indian breast cancer patients and Western breast cancer patients, what are the differences? What we see in Indian patients, we are seeing women at a much younger age, almost a decade earlier than the Western women. Western women are like largely postmenopausal, with 60 being the median age at diagnosis, whereas it is 48 for the Indian women. And the Western women, they are usually screen detected tumors, hence we see smaller tumors, more negative tumors, whereas in Indian patients, what we see is patients are getting detected later, and we see much more cases who are who have node positivity, even if it is one node positivity. So we have symptomatic detection and primarily stage 2 detection of cases, whereas in Western we see more of stage 1 cases. Hence, our problems are disease onset at younger age among Indian patients, and we see more of node positive and also higher grade patients, and we also see patients who have higher Ki-67. Now, this is a proliferation marker, and what we need is a prognostic test which is suitable to our patients. So what are prognostic tests? As I already mentioned, these help us assess the chance of cancer recurrence. So they help us identify the patients who require chemotherapy. In the West, Oncotype DX and MammaPrint have been there for over 15 plus years, and they have widespread acceptability in US and Europe, and these are widely adopted there. These are largely, insurance-driven markets, and the acceptability is so good that these are included in the, the guidelines of the countries as treatment guidelines for these patients. So NCCN, ESMO, NICE, ASCO International Treatment Guidelines, and also AJCC prognostic staging system. They include this prognostic test as part of the treatment guidelines. This has led to a large reduction in the chemotherapy use in the Western countries, leading to improved quality of life. So typically the women, the patients who are diagnosed with hormone receptor positive, HER2 negative early breast cancer, they undergo surgery, and subsequently they undertake a prognostic test. This prognostic test helps to know whether these patients are at low risk of recurrence, that is, they do not require chemotherapy, or they are at high risk of recurrence and they require chemotherapy. However, Indian ICMR is in the ICMR consensus document on breast cancer management, it specifies that this multi-gene signatures like MammaPrint and ODX are not showing any clinical utility or added value in practice, as there is very little data on Indian patients. So the innovative development from our side has been the development of CAN-Assist breast. Now, the journey of CAN-Assist breast and OncoStem diagnostics started 11 years back. In 2011, when Dr. Manjari Bakri, award-winning and very experienced cell biologist, started OncoStem diagnostics as a startup. Now, over the years, in 2016, we had the commercial launch of the CAN-Assist breast. This CAN-Assist breast, what is the CAN-Assist breast? I'll be talking a lot about it now. To start with, it integrates data from 5 biomarkers, which is tested on immunohistochemistry platform. And this is a gold standard platform, and it helps us to look at the biomarker expression. And these biomarkers are play critical role in signaling pathways in tumor recurrence. These are combined with the morphometric parameters such as tumor size, grade, and node status. And these are incorporated again into AI or machine learning based statistical algorithm, and a CAN-Assist breast risk score is derived. This risk score could be anything from 0 to 100, with 15.5 as the cutoff. So 15.5 and less is categorized as low risk. And this is typically around 70% of the patients. And these are the patients who can safely avoid chemotherapy. And 15.6 and above patients are the ones who are categorized as high risk. And these are the patients who benefit from chemotherapy. Here, I'd like to say that we have done a lot of validation studies, and this is close to 4,000 patients from India, US, and Europe. And we have managed to demonstrate very high accuracy with over 95% negative predictive value, which is comparable to that of the Western test. Here, I'd like to just say what is negative predictive value. So if CAN-Assist breast calls a patient as low risk, and the patient is rated as low risk, that is with endocrine therapy alone, and subsequently at the end of 5 years, if the patient does not show any event, that would be the metastasis, that would be what would be the indicator to show that the test is working as intended. So that is the negative predictive value. The biomarkers included in CAN-Assist breast, the patent is granted across multiple countries in India, US, China, Europe, Canada, and we have publications in several peer-reviewed journals. What is the actual utility? Now, to understand this better, I'd like you to take through some of these patients. Now, these are patients who actually are the kind of patients that clinicians, treat, and these are the patients who, pose a significant dilemma to the clinician on how to treat them. Names have all been changed to protect privacy. And the first patient Renal, she's a 31-year-old patient who was recently married and wanted to have a baby. She was diagnosed with stage 2 breast cancer and with very high Ki-67. And typically the clinician, because of the fact that they want to take the patient's life choices into consideration, they're wondering how to treat this patient so that she can achieve what she wants and be treated safely. So this patient underwent Canis's breast testing. Again, same way, there is a patient, Jessie, who did not want chemotherapy. She had high Ki-67 stage 2 breast cancer. And there's another patient, Kritika, who was a 56-year-old lady. She was quite hesitant about chemotherapy and, and the financial implications of chemotherapy, grade 3 patient, breast cancer with high Ki-67. So, what eventually happens in these patients is the requirement of testing a prognostic platform, which is going to work for them. So with this in mind, OncoStem developed, and this is the detail of the publication of the novel proteomic classifier. So as against all the genomic classifiers that are available in the West, this is a proteomic classifier, and it works on the gold standard immunohistochemistry platform. And it uses, and it has at its heart or core the AI ML based algorithm, which is a support vector machine algorithm. And that this publication is available in Biomarker Insights. So coming to what are the biomarkers which are there in Canis's breast. Now, it's a typically asked question is whether these are the ER/PR, HER2/neu, or are these the proliferation marker Ki-67? Now, this is a very frequent question because, there are a lot of online, equations which are available, IHC4 and all that. So people do get confused and they think whether we are using these two. We do not. So the biomarkers that we are using, these are the biomarkers which play, very critical, which are part of very critical events in cancer progression. So when the cancer starts in the duct, what is it that allows that cancer to become a metastasis? So it firstly undergoes epithelial mesenchymal transition, and subsequently there's a loss of cell-to-cell addition or dissociation of these tumor cells, and they subsequently invade the blood vessels. Now, this blood vessels is a very hostile environment for a cancer cell, but they're able to survive that, and they eventually undergo extravasation, and there is mesenchymal epithelial transition. And, again, in the process, there is acquisition of chemotherapy or drug resistance, and subsequently the tumor cell is able to, form a distant metastasis in, say brain, bone marrow, or, lung. So these, while, it looks like it's a very simple chain, actually all these events, they are occurring at tandem, and they have multiple, pathways which are happening. And while we started with the development of the test, over 40 biomarkers were analyzed, and these 5 biomarkers were chosen because of the statistical significance in the way the biomarkers are able to determine the high risk and low risk patients. And any test to show that it works very well, analytical validation is a must. Ours is an IHC based test, and we follow the EGAP and CAP and CLSI guidelines for doing the validation, analytical validation of the test, and all this is published. So basically it shows that all the variables, reproducibility and repeatability is very good, with showing that there is good intra observer, inter operator and repeat runs. There is a very good reproducibility, and it is a robust test. We've also validated Canis's breast on automated platform and in TMA. And now this is a very important part. One is the analytical validation, and second, or the most important part, is the clinical validation, meaning to say that, how does it work in the intended population? So while, Canis's was developed on Indian patients with the fact that, we wanted, right from the beginning, it was Dr. Manjari's vision to take it across to the globe, so that anybody anywhere in the world, whether it is Africa, America, or Europe, is able to prescribe the test and benefit from using the test. So we have participated in around 18 clinical studies with over 4,000 patients across very reputed oncology centers in US, Europe, and also in India, very premier institutes in India. And this has been tremendous opportunity for us to interact with all this, very elite set of oncologists who shared their, knowledge, and we were able to use that to develop the test. Clinical validation of immunohistochemistry based CAN-assist breast has multiple publications. I'm just sharing the details of screenshots of this. I will also be subsequently sharing the links to the publications which you can go through. And we have also done a head-to-head comparison of CAN-assist breast with Oncotype DX that is also published. I'll be speaking a little bit about it later. And this is from our most recent paper, which was a retrospective validation of CAN-assist breast in European early breast cancer patients. This is around 864 patients from 4 countries who underwent CAN-assist breast testing. And what was seen was the fact that CAN-assist is robust and it functions independent of the ethnic or geographical differences, and it can be used for optimum therapy planning in the European breast cancer patients. So coming to the CAN-assist breast test flow, this is just one slide to show you how we do the test, what happens when the test comes to the lab. And then we receive the sample in the laboratory, it undergoes sectioning. We look at the H&E to see whether there is sufficient tumor content for evaluation, and if sufficient tumor is present, it goes for IHC testing for CAB biomarkers, and these are done on Ventana benchmark XT. Here I'd like to say that every CAB biomarker is accompanied by known quality control, both positive and negative cases, and only upon acceptance of the QC slide are the test cases evaluated. Subsequently, CAB IHC scoring is done by experienced trained pathologists, and the input from the CAB IHC's grading and the morphometric parameters is integrated into the MI algorithm, and what we see is what happens is the prediction. So it gives us the risk score. So with the risk score, the report is generated, and subsequently the report is dispatched. This is just to interest any pathologists in the crowd or even students of pathology to see what exactly is the role that the pathologists play in this entire process. So when you do an H&E review, we look at the tumor content, we look at the histopathological grading and scoring, and we also look for any other confounding factors like necrosis, sclerosis, or suboptimal fixation, or any other interfering factors which may interfere with the test. We identify the invasive tumor component. Sometimes we can mark them if it's required. Also, we identify any internal control, like normal breast tissue or DCIS tissue which is present. And if multiple blocks are submitted, we identify which is the best block for testing. And subsequently, after the staining on Ventana benchmark XT, the samples come to the pathologist again back for grading. We look at first the batch controls, which, as I already mentioned, includes positive and negative. And once those are acceptable, we look at the test tissue itself. Firstly, the test tissue, we identify if there is any internal control present, which is the normal ducts, and see if it shows appropriate staining. Then we go on to grade the percentage and intensity of the invasive component. We have 5 biomarkers in our CAN-assist breast testing. It's CD44, ABCC4, ABCC11, N and pancadrin. CD44, ABCC4 and 11 are looked at the membranous location, and N-cadrin and pancadrin are looked at the cytoplasmic location. So subsequently, the pathologists analyze the percentage of cells which are stained with membranocytoplasm. This can range anything from 0 to 100, and this is seen as the average of all scores after scanning the entire invasive tumor percentage. Intensity of the staining can vary from 1 to 3, with 1 being the lightest and 3 being the darkest. These are just some representative images to show how high expression in membranous location would look and how low expression in membranous location would look. Now, to the pathologists who are already reporting HER2/neu, this would look very familiar. Also, as you can see in the down panel here, what we see is the high expression in cytoplasmic location and low expression in cytoplasmic location. So Here, since we have the crowd of future doctors, I would like to specify that fixation is very, very important in all oncology, and more so for any predictive or prognostic markers. So when to fix promptly within less than an hour of surgical resection, which is called as the cold ischemia time. And what do you fix it? It has to be 10% neutral buffered formalin, and it needs to be fixed for 6 to 72 hours. It is also very important to note the cold ischemia time, fixation time, and the fixative details in the test requisition, so that we understand that the fixation has been good, and it helps us to assess, and in the report to give a remark on the fixation of the specimen. So now I'd be discussing about the Canisius breast data. Now it would be a bit technical. Just to make it easy, I'm going to stick to the key points alone for this. I will be talking a lot about Kaplan-Meier survival curves. What are the Kaplan-Meier survival curves? These are the survival curves which look at any one parameter, like say a treatment or like here a prognostic test, and see that how the survival goes. So typically what we see is, on the x-axis we have the distant metastasis-free survival, and on the x-axis we have the time in months. So when we are using say Canisius breast and we see the low and high risk parameters, what we can see here, this is the blue line is the Canisius low risk patient. So 69% of the patient has been categorized as low risk patients, and this is the DMFS which is seen, which is 95, which is a very good DMFS. And high risk is 31% of the patients. This is again 82% DMFS for this patient. And you can see that segregation needs to be good to be able to be for that, show that the test works very well. So what we can see here, the p-value of this segregation is statistically significant. Now this is the entire cohort of almost 2,500 patients who received chemoendocrine therapy. So subsequently, we also looked at patients who received only endocrine therapy. This was basically to see if chemotherapy was in any way confounding the results of the test. So when we see the endocrine therapy alone patient, now I do not know, this is a retrospective analysis. I do not know for what reason the patient, these set of patients received endocrine therapy alone. Possibly they were, thought of as clinically low risk, or they had some other comorbidities which did not allow them to be given chemotherapy. But even in these patients, what we see is Canisius is able to segregate 14% of these patients as high risk who have a poorer DMFS of 85 as against the 96 DMFS in the low risk category. So what we see is that Canisius breast works very well with the NPV of more than 95%, and it is unaffected by chemotherapy. Now again, for a test to know that how the test works, we need to, and as I mentioned earlier also, in Indian setup, what we see is the younger patients. So we are interested to see that, how it works in younger patients. Does it work as good or not? So what we see here are the two, again, these two graphs, which is, patients, the entire cohort with patients less than 50 years and more than 50 years analyzed separately as subcohorts. And what we see is that, Canisius segregates almost similar proportion of patients, which is close to 70% of the patients as low risk and 30% as high risk. And what we see is, low risk patients have a better DMFS in both the things, almost, less than 50 and more than 50. Again, we see that a statistically significant segregation is happening. And as expected, we see that in the postmenopausal or the more than 50 years of women, we see slightly improved DMFS. Anyway, what we see here is that Canisius is able to stratify patients across different ages. That is the in the nutshell of this slide. So coming to node, again I mentioned in the earlier stage slide that node positive cases are much more common in Indian setup. We see 1 node positive or 1 to 3 node positive patients. They're very common. So we looked at patients who are node negative and node positive to see how does Canisius best perform. So in the node negative patients, what we see is in that also the Canisius is able to identify this 18% of the patients who are Canisius high risk and who would benefit from chemotherapy. We can see that there's a fairly good segregation of this patient. Look at the statistically significant p-value here. And coming to the node positive patients, as is expected, the proportions are slightly different. What we see is a much higher proportion of high-risk patients. But again, here also I would say 48% is a good number of patients who are identified as low risk. And this, in spite of being node positive, these are the patients who do not require chemotherapy. So CANASYS has shown that it works very well in node positive patients also. So coming to clinically low risk patients, now typically in India, the tendency is to go by the clinical, risk analysis or clinical parameters to decide on the use of endocrine therapy or chemoendocrine therapy option. Now, these are the patients who are clinically thought of as low risk, and these were treated with endocrine therapy alone. This is first graph here is T1 node negative patients. Here also what I want to just emphasize here is, even in this clinically low risk patient, CANASYS is able to identify the 7% of patients as high risk who have a poor DMFS. Again, in T1, T2 category also, again, what we see is this 9% of the patients who are again at high risk. So I mean to say that it works in both ways. One, we are able to identify the patients who are low risk and who need not be given chemotherapy. And also it works in other way. That is, it identifies in the so-called clinical low risk patients, this set of patients who are high risk and who will benefit from chemotherapy. So this is what is personalized treatment. So now to look at what is the chemotherapy benefit in the high risk patients, we looked at the data a little bit differently. We saw all the patients who are, CANASYS breast low risk. These were basically categorized based on what was the treatment that they received. This blue line here is the patients who received chemoendocrine therapy, and red line here is the ones who received only endocrine therapy. And what we see here is that these lines are very superimposing, and DMFS is same, 96%. So what does it mean? It means that CANASYS breast low risk patients do well whether they receive chemotherapy or they receive chemoendocrine therapy. And there is no statistical difference in the way these patients behave. Whereas when you look at the high risk patients, and these are the patients, now this is a retrospective analysis, in the high risk patients, there are the set of patients who were only treated with endocrine therapy. Look at the DMFS, it's 79%, whereas the patients who were identified as high risk and who received chemoendocrine therapy, they show a much better DMFS of 93%. This 14% difference, this is what demonstrates that chemotherapy only in the high risk. So now coming to the fact that, do all prognostic tests perform similarly across different races and ethnicities? I would like to share some inputs from this presentation. If you look at this bar graphs, what we see here in this box corner here are the publications which are coming from Japan and South Korean cohorts. Typically what happens in Mama Print, as is published in most of the American or European studies, we see a 60% of the patients, 55 to 60% of the patients were categorized as low risk and remaining as high risk. Whereas what we see here in the publications from Japan and Korea is that, around 80 to 86% of the patients are being categorized as high risk, whereas only, very small section of 20 or less than 15% were getting categorized as low risk. So what I mean to say is it works in a different way across different ethnicities. So it just goes on to emphasize the fact that you need to look at the intended population, and we need to validate the test in the intended population to be able to use any prognostic test in a successful manner. So this, just to highlight, or I'll just say one keyword from this, very busy slide. It is from the post hoc analysis of this excellent TAILOR-X trial. This TAILOR-X trial had over 10,000 patients in some 950 centers across North America and some centers in South America. Then when they saw that how is the overall survival of invasive disease-free survival or distance recurrence-free interval between Black and non-Hispanic women versus white and Hispanics, what they saw was much higher hazard ratios. So meaning to say that, they showed that these tests are not working as intended in the, Black versus white population. So with this in mind, what we did is we looked at our own data and we saw that how is our test performing in, say, the Indian subcohort versus the Caucasian subcohort. Caucasian subcohort is the cohort which is from all our European studies. I will not get into the details of this slide. It's a very busy slide. What I mean to say is it shows that in all the cohorts, the proportions are fairly similar, and it is showing that, it works almost similarly well. So that the accuracy of Canis's breast is independent of the ethnicities or the geographic differences is what I'd like to emphasize on this slide. Coming to Ki-67 based risk stratification. Now, Ki-67 is a proliferative marker, and a lot of clinicians use it very well. Though Ki-67 is ridden with its own problems, there have been a lot of changes in cutoffs, and this is one of the common cutoffs, and this is also used for luminal AB classification. Ki-67 of less than 14%. When we looked at this cohort of almost 877 patients, to see who had Ki-67 less than 14%, 54% were identified as low risk, and 46% as high risk. And look at the difference in the DMFS of the two. It's only 3%. Whereas the same patients, when they underwent Canis's testing, we are able to identify more number, which is 77% of the patients are identified as low risk, and they have a DMFS of 95, as against DMFS of 81 for the 23% of the patients. So it is able to segregate the patients much better than Ki-67, and it's able to prevent over-treatment in many more patients. So it works in a much better way than Ki-67. Luminal AB subclassification is also one of the very popular classifications which is used. So what we see, when these patients undergo luminal AB classification, luminal A is typically what is called as the low risk. Around 31% of the patients are categorized as low risk when you do segregation according to luminal AB subtype. Whereas when we use the same patients are tested with Canis's, 75% of the patients are segregated as low risk, and look at the difference in the DMFS. It is 13%, I guess, as against the 3% difference in the DMFS here. So it works even better than the luminal AB classification. Now here I'm very excited to share some data from one of our recent studies. So Canis's breast, how does it work in long term? We've been very curious about this, and we were able to look at the 10-year recurrence risk prediction by Canis's breast with using some data from the TEAM trial. TEAM trial is tamoxifen exemestane adjuvant multinational trial. It was a large multi-country prospective randomized clinical trials, and it had more than 12 hours of follow-up available on the clinical outcomes. And in this, we were able to validate Canis's in the 480 patients tumor blocks from one particular center, that is Leiden University Medical Center in Netherlands. I will not go into the entire cohort description. I will just go on to say that it's largely a postmenopausal cohort, node positive, and all these patients were treated with hormone therapy alone. So just, not going too much into the details, what I want to say is that even in the 10-year period, we see that, Canis's is able to work in a statistically significant manner to segregate the patients. So look at the, and the proportions are 68 to 32, which is along the lines of that in any of the previous publications. And look at the difference in the DMFS in the 10-year follow-up period also. So this, again, we looked at the patients who are node positive in this. So when we looked at the 0 to 5 year, follow-up for the node positive patient, 63% of patients were categorized as low risk, which have this DMFS of 92%. Now here, I'd like to say that in the RxPonder, what DMFS Oncotype DX is shown is 91.9%. These are the women who have recurrence risk scores of 0 to 25 in postmenopausal women with node positive disease. Now these are equivalent. So what I wanted to say is that Canis's is working as well as Oncotype DX in this category of patients also. So coming to comparison CanAssist with other multi-gene tests which are there in the market. As I mentioned earlier, we have done the comparison of breast cancer prognostic test ODX, which is a head-to-head comparison. And what we have seen is that in the low risk category, that is the patients who are not to be given chemotherapy, in this we have, more than 83% of the patients, close to 83% of the patients, there is concordance in the risk category. Just looking at little bit of the data from the same, what we, from this publication, what we see is CanAssist identified 83% of the patients as low risk, whereas Oncotype DX identified 90% as low risk. And what we saw here is, the same patient, when you look at it, in that there is 83% concordance. And as we can see, the NPV is also comparable to that of ODX. Coming on to CanAssist versus MammaPrint, again, when we did, CanAssist breast testing of the same cohort of patients in head-to-head comparison, what CanAssist categorized 67% of the patients as low risk, whereas MammaPrint identified 55% as low risk. And when the same patients were analyzed, what we saw is a 85% concordance between MammaPrint and CanAssist breast in a low risk category. Now, here I'd like to say that, this is the test which is developed in Indian patients, and also it is highly cost effective. It's almost at 1/5 the cost of any of these, internationally available tests. So, how is CanAssist breast helping patients? Here I'd say that CanAssist breast reach is, spreading wider with each passing day, and it has been prescribed by over 300 doctors across 40 cities in India, Turkey, UAE, Sri Lanka, Bangladesh, and more than 2,000 patients have been prospectively tested till date, and 71% of these patients have been classified as low risk, and thus have been able to avoid chemotherapy, leading to huge savings. And we also, have CanAssist is can be reimbursed on insurance. There are many, insurance providers, and if any patient needs this, if they reach out to us, we have, our coordinator who will help you go through the process and to get the medical reimbursement. There's also public reimbursement with CGHS, Indian Oil Corporation, SBI, all this also giving reimbursement for our test. So if you remember these 3 patients that I had mentioned at the beginning, these 3 patients now, actually, these are the patients which actually happened in the first year of our, sales as at 2016. And these are actually the success stories of our test, and I'd like to share with you. Remember the 31-year-old lady who wished to have a child, and this patient on CanAssist breast risk score was categorized as low risk, and instead of the conventional multimodal treatment, which would have not allowed her life choice to happen, the treating doctor, he skipped chemotherapy for her, and he gave her a year to plan for her pregnancy. The patient had a healthy baby, and she's been put on endocrine therapy post her delivery, and it's been 5 years since the diagnosis. She's doing fine, and she's mother of a healthy child now. And this is the second patient, Jessie, again, 36-year-old lady who was not wanting to take chemotherapy, stage 2 breast cancer with high Ki67. Again, this would conventionally have gone for chemotherapy. However, on CanAssist breast categorization, she was low risk, and the clinician was able to safely skip chemotherapy and put her on endocrine therapy. She has finished 5 years of follow-up, and the patient is doing very well. Again, this third patient, a 56-year-old lady, was hesitant to take chemotherapy on account of both her age and the cost of chemotherapy. This patient again was also categorized as low risk, and this patient was very happy that she was able to skip chemotherapy, and the patient has been doing really well on the 5-year follow-up. So CanAssist breast is impacting clinical treatment decisions in early stage hormone receptive breast cancers, and there is a publication on this in the Indian scenario. This talks about over 1,100 Indian patients, and what we see is 92% of the patients who are categorized as low risk by CanAssist, they were followed up with only endocrine. They were treated only with endocrine therapy, and what we see is in the entire cohort, almost 80. I think it's 88% of the patients who were actually treated according to CANASYS, whether to receive chemotherapy or not. Also, this is one slide again, which I'm very happy to share. What do oncologists think about CANASYS breast? Now, this is a consortium of oncologists from premier oncology institutes in India. They have included CANASYS breast in the practical consensus recommendations for optimizing risk versus benefit of chemotherapy in patients with HR positive, HER2 negative early breast cancer in India. In fact, they have recognized CANASYS as one of the only tests which is having validation in Indian population, and they have recommended that CANASYS low-risk patients be treated with endocrine therapy and high-risk patients be treated with chemoendocrine therapy. And also many other oncologists have, spoken about us and published in, journals and spoken about in very, important media mentions about how they believe in CANASYS and how it is changing, the breast cancer patient treatment in India. And many reputed oncologists like Dr. S.V.S. Dev from AIIMS, New Delhi, they also recognize CANASYS breast as a breakthrough for breast cancer management in India. And Dr. Harit Chaturvedi from Max, Dr. Ramakant Deshpande from Asian Cancer Institute, Mumbai, Dr. Sandeep Kumar again from AIIMS, they were all spoken and given in media mentions about how CANASYS breast is actually helping their patients. Oncologists in Turkey have also spoken about our test and saying that how it is helping them also to choose therapy for the patients. In last year's APSICON 21, again we had I think Dr. S.V.S. Dev spoke about, and Dr. Bapna presented his his own personal experience in NATCON 21 on his patients who have taken CANASYS breast and how the CANASYS has helped optimize treatment for these patients. So why CANASYS breast? First thing, it has multi-country validation. It is validated on Indian patients who are much younger. And I'd like to remind that most of the Caucasian patients or the tests which are developed on Caucasian patients have been developed on the postmenopausal women. So here we have, a test which is validated on the younger Indian patients. It is an affordable innovation. It's priced 4 to 5 times lower than that of the competitors. And it has at its core AI or ML based algorithm. And this is practically the only prognostic test which has any potential for drug development. The biomarkers, which are proteins, which are the effector molecules in the cell, these are the ones which are the, give you scope for targeted therapy. And here I'm very happy to share as the lab director that we are a very quality driven laboratory. We have CE marked and we have ISO 13485. We are accredited by College of American Pathologists and NABL. And we have one of the fastest turnaround times in the this category of 7 to 8 days. So just to summarize, I want to emphasize that CANASYS, the innovative solution from us, is a robust and cost-effective immunohistochemistry-based prognostic test, and chemotherapy benefit is observed only in CANASYS breast high-risk patients, and over 83% concordance is observed between CANASYS breast low-risk and Oncotype DX or MammaPrint low-risk categories, and CAB stratifies patients more accurately than Ki67 luminal AB and IHC4 based stratification. Here in my talk, I have not shared the IHC4 based data, but it is available in our European publication, and I would be very happy to share with anybody who's interested in this. So it prevents undertreatment and overtreatment of patients, and early data has shown that CANASYS has saved 71% of patients from chemotherapy in a prospective manner in India till date, and patients based on CAB are showing excellent outcomes post 5 years of follow-up. And we have a multi-country validation, and it works independent of cohort-specific differences, age and node status. And here I would like to just say, this is because of the fact that, CANASYS breast biomarkers look at some critical part of tumor biology. These are the markers which play, very crucial role in, which are in, events in, cancer progression or tumor aggressiveness. So CD44, which is a stemness marker, or ABCC4, ABCC11, these are the ones which are involved in drug resistance, or the pancadrins, which are important in addition, which are important in dissociation or loss of cell-to-cell addition. So these are the ones which are able to identify the the relevant tumor biology related points and help Kinesis to perform very well. Again, this is just as I mentioned already earlier. We have multiple patents. We are very quality conscious, and I've already shared that. And this is our management team. We have at our heart Dr. Manjari Bakre, our founder and CEO. She's a lot of awards, and she's the vision and the heart of Kinesis and OncoStem team. And we have all other Dr. Aparna, Mr. Satyanarayan Thallam, and Mr. Praveen Bose, who bring lots of years of very relevant experience to the table. And our advisory board has some marquee sectoral experts, Dr. Nagendra Swami, Dr. Harit Chaturvedi, Dr. Govind Babu, Dr. Somashekar. These are all been our advisors. And this is a list of all the evidence and publications, and the links. If anybody is interested, you can drop in an email to me. I'll be more than happy to share. Again, this is just, we have been, Dr. Manjari and OncoStem have received multiple awards over the years, and there's just, just a slight to include that. And last but not the least, I would like to thank you all from Team OncoStem. We are very happy to be able to make a real change in the lives of breast cancer patients. And also, this is my email ID, and we are very happy to collaborate with anybody on any studies, and also any queries that you may have. I'm very happy to answer them. So I'm open to any questions.
Very interesting talk.
Thank you, sir. Thank you so much.
So one question to you is that this is now all over India, it is accepted, this one?
Yes, it is accepted very well all over India. We get samples from almost all premium oncology centers. This is practically the only test which has Indian validation. So, Western tests when we are doing, we do not know how it works in the Indian population. But whereas Kinesis has the extensive validation in Indian patients, we know that it works very well in the Indian patients.
Basically, it is a histochemistry based test.
Not histochemistry, immunohistochemistry based test.
Immunohistochemistry. So generally, when the nodes are there, we take probably it is metastasis there clinically.
Yeah.
I'm a pediatrician, I'm not a surgeon. So your test says even if lymph node is there, majority of them do not require chemotherapy.
So here I can, I can just say one thing actually, that not all patients with node positive breast cancers need chemotherapy. RxPonder trial, which is the it's a prospective trial, it has also proven that patients with 1 to 3 node positive, based on the recurrence score, the low risk, which is the RS less than 25, these patients do not benefit from chemotherapy. So this is it's a well-known and very accepted fact now that not all patients require, even with node positivity, there is a segment of patients who do not benefit from chemotherapy.
And
yes, you would continue, madam.
no, sir, please.
No, this endocrine therapy, once you give, what is the longest period of follow-up you have? Because recurrence, I just wanted to know.
So we have now with team trial data published, we published a poster on the team trial data in ESMO, which is European Society for Medical Oncology. So basically, it is a 10-year follow-up that we have. So as we know that hormone receptor positive patients have this, another type of recurrence which happens at, post 5 years. So this covers that. So we have 10-year data to show that Kinesis works very well.
So we can basically define low risk as well as high risk separately. And if low risk are there, for them there is not much difference if you give chemo endotherapy and endotherapy. There is not much difference in outcome.
These are the
Whereas in
patients-
high risk, definitely it is more useful.
Definitely. They are the patients who will benefit from chemotherapy. You're right.
But in that also, he said that 17% only will be benefited. Something like that. I really not
No,
sure.
ma'am.
It is
Actually,
like that.
what we see is a percentage, but they say improve survival actually. So that what we are seeing is a 14% difference between the survival rates. 14%.
Survival.
Yeah, survival rates. 14% is a lot of survival rates when you look for how the therapy or the test works actually.
So low risk we can put on endocrine therapy, right? So that's how about 70% people can be just eliminated from chemo.
Yes, so that
Yeah, I can
the cost
understand.
benefit is. Look at the cost of chemotherapy now.
Not only cost, suffering.
Suffering, and sometimes patients go into all these complications. They can go into neutropenias. There's so many complications that can happen. There's a cost to that also. And in India, typically the patients who are taking chemotherapy, some family caregiver or daughter, son, relative, wife, husband, somebody has to accompany. They have to leave their job and they have to come. So every time the chemotherapy is a long process. Also, it's not like it happens in one and it's over. So much of costing of that also. That caregiver also spends their money and time, and chemotherapy is expensive, and sometimes we see some adverse effects. Actually, patients who are not benefiting any treatment, when we decide, it's the benefit to risk that we analyze. So that is where Canis's scores. And
any questions from my audience?
Questions for the students. Actually, I hope I was able to get through to you, and it was not too boring and very technical. Though of course we are working in very technical areas, I could skip the technical part completely. But I do hope that you're able to understand how the test works, and also, very important thing is that in India also we can work and we can make solutions which can cater to the entire world. So all the other tests are coming from West actually, we who are flush with funds, and they work in a different way. So but in India also, if you have the will like Dr. Manjari had, you can make a difference. I hope that came across.
So that is for Make in India.
Make in India.
You have proved that our Indians can do that.
Absolutely.
Yeah. Any questions from anyone? Ravi Kumar?
It's very clear.
It was a very interesting talk. Because students, of course, may be a little different level. So probably sometimes they may not be interested that much in the technical part of it. I think they should appreciate how artificial intelligence is used.
Yeah. Important thing is to see how Indians are at the forefront of innovation actually. So we are making a difference to the world. So,
that should stimulate our students.
Absolutely. You can do what you want. You can do it.
They have to look for the problems and how it can be solved with the teamwork. So maybe cellular biologists, AI people, all with that.
Absolutely.
It's really interesting thing. That another very interesting, I felt that we can avoid chemotherapy.
Yes, absolutely.
Because we day in and out, we see this patient, not only physical suffering, their mental suffering also. So
and there's so much of fear of chemotherapy actually.
Even for us. Even for us.
The patient imagines that all hair has fallen out. So
Here for both the doctor and patient.
Yes. We don't want patient to suffer due to our therapy itself.
Right. Absolutely, absolutely.
Someone has raised hand in audience.
Yeah,
Any question there in the hall?
No, ma'am, there don't seem to be a raised hand.
I think we can go to the coordinator. I think.
Okay. Okay, ma'am. So I think I should extend our collective gratitude Gratitude to you, ma'am, for the knowledge you have shared with us today. Thank you, ma'am. I now invite Dr. Pushpa Kothur, ma'am, to give a formal summary of our today's program.
Thank you, Sanjay. First lecture of this session was very interesting to know that without any invasion, we can diagnose breast cancer at earliest stage. And that was really very important. And I congratulate Dr. Geeta for this. And very nicely, she has explained how first, initially, she explained what are the basics of artificial intelligence, creating different pattern and different objects, different things. Then they will train the computer by putting these different images. So that is very interesting. I found that we were not knowing how this AI works, but she really explained it in a very beautiful manner and giving example of child and images of cat and dogs and like that of objects. Then next thing is how it is merged with our medicine, how it is helping us in imaging, medical imaging, and how we are coming to the point where without any, not even touching the patient, we can diagnose certain abnormal masses, abnormal areas, potential areas of cancer. And the beauty of this thing is it is affordable to all. And you can reach even to rural area with this particular innovative thing. And our radiologists are really burdened with the investigations. We get it done from them all the time. We will be nagging them, do MRI, do CT, do this, do that. So all this can be just, minimized. So their burden is reduced by just screening this. And this is, since women don't like these all invasive techniques much, without any touch, without any seeing, without any, she told some three, no see, no touch, no invasion. So this technique really I fascinated me, and I really look forward for such technique can be developed in cervical cancer as well, because our women who stay in rural area, we can reach them with this small instrument. So that is one thing, because we had a lot of limitations with mammography. It is a painful procedure, exposure to a lot of radiation. Patients really don't like, and more than anything, cost. And such a big equipment, we cannot take it to the rural area. Actually, we had through Rotary, one person had the one mobile van which was carrying mammography. But it's really very difficult, not very practical to reach everywhere. But this is a small thing which we can reach with that. Then its accuracy, specificity, sensitivity, you can say 100%, that is really commendable. But maybe sometimes false positive can happen where the thermal points which are there, heat generation will be more where there is an inflammation or where there is any other thing also. Here the thermal signatures are actually, they are converted and they are analyzed by the artificial intelligence. That's how it works. But mainly we are interested in its more applicability. About our Can Assist, I really congratulate these people, because I told that chemotherapy is one which really matters a lot for doctors as well as patient. So we doctors are also equally hesitant to offer anyone chemotherapy, and especially already because of cancer, these patients are debilitated, their all counts have gone down, and then again we have to give even blood transfusion sometimes, which is also risky. Then blood components sometimes we have to give. So all these things can be just, you can get away with all these things if you are told that your patient doesn't need chemotherapy. Endocrine therapy, it's okay. So that is one thing I really fascinated to me. And they how does it work? They integrate data of 5 biomarkers which they collect from immunochemistry, through immunochemistry of the tissue, and that data is analyzed with like their critical signaling pathways will be analyzed, and then they will be studied by machine learning. So this is a really highly, highly, you can say, appreciable thing, which will reduce our burden and our anxiety towards patient, and it will really help for better patient care. And I congratulate both speakers of today, and I really happy that this program was really successful because of these two eminent speakers who have done a really hard work and research, and they have shared our experience. So thank you, Dr. Savita. Thank you so much.
Thank you so much. Thank you.
Sanchit?
Yes, ma'am, I'm here. Coming close to the end of the program now, I would like to invite Nikhil Tomar, one of our dearest first-year MBBS students, for a vote of thanks.
You don't want to, sir, you don't want to talk about something to summarize the talk, or your remarks also are very important, sir.
See, whatever I have to talk, I have already, both the speakers were excellent. And it's very important to note that whatever they have talked about artificial intelligence developed in India, that's more important. See, always we see, look at the West, what they develop, what they do. So they have shown the way that we can do similar or better than the other countries. So it should be an inspiration for all our students to think and act in whatever way they can. So thank you very much for both the speakers, Dr. Geeta and Dr. Savita. And I wish you all the best for more discoveries and more action on artificial intelligence in the future. Maybe we can collaborate in some areas so that
Definitely, sir.
it will help our students and faculty members.
Definitely, we'll be very happy.
You can continue.
Sachit?
So this brings us to the end of this program. With due respect to the joining hands who made this meeting a success, I would like to thank our guest speaker, B.A. Savita ma'am, for sharing her thoughts on our problem, our innovative solution. And I also like to thank Dr. Geeta Manjunath ma'am for enlightening us on AI for medical imaging and innovation in early diagnosis of breast cancer. I thank all HOIs and HODs of various institutes and departments. I would like to thank our Dean Professor, Dr. P.F. Kutu sir. Without his support and encouragement, this event would not have been possible. I also thank our respected Dean H.V. ma'am, Dr. Mahalakshmi, for her continued support in these events. I thank our President of IISc, Dr. Vishnu Bhatt sir, Director of Medical Research, and our convener of IISc, Dr. Pushpa Kutur ma'am, our pillars of support, without whom these events would not have been possible. I thank our Vice Principal, Dr. Rajan sir, and Dr. Arunacham sir. At last, I would like to thank our faculty members and audience for participating in this event. Thank you, sir. Thank you, all of them. Ma'am, can we close the program now?
I think so.
Yeah.
Thank you, ma'am. Thank you, sir.
Thank you, Dr. Savita.
Thank you, ma'am.
Looking forward to collaborate with Can Assist in future.
Definitely. Thank you so much.
Okay.
Good day.
Ravi Kumar,
Yes, madam.
this thing was not taken, no? Screenshot
All screenshot have been taken. madam.
taken, but they should put their videos on students.
Initially, we have all the first screen was been open.
Maybe it is in
So
the
that-
record also.
This-
Record.
No, but students who were sitting in
The full batch of students are
auditorium.
sitting there.
So that is okay, no, because we are registering also.
Yes, madam.
Okay. Thank you. Let us now end the
Vishwanath.
program.
Okay, ma'am.
Okay. Thank you so
Thank-
much, Ravi. Ravi Kumar, thank you so much. Everything went on well.
Thank you.
Oh, Sanjit?
Sir.
Don't just wait. I'll be coming over there.
Okay, sir. Okay.
Because the
Sanjit,
program is
one
starting.
more thing for students.
Yes,
We
sir.
have to tell
Yes,
that we will be sharing some feedback forms and assessment forms.
Okay, ma'am.
Those questions we will be sharing. They have to upload that,
Okay, ma'am.
and attendance will be based on registration and uploading.
Okay, ma'am. I'll get them to fill the assessment forms. Yes, ma'am.
Yeah. Okay. Thank you.
Thank you, ma'am.
Are we signing off, madam?
Yes, sir. But I don't know why Ravi Kumar said I will be coming there. Please don't switch. Sign up. I don't know. I think students can sign off, no? Now? Ravi Kumar? I think Ravi Kumar is going to come there to MEU.